Greetings everyone! Welcome to the Mini Learning Symposium presented by NPK Medical Trading Incorporated. It is an honor and privilege to be part of the 73rd Annual Convention of the Philippine College of Radiology. This is going to be a 2-day mini session plus a 1-day pre-congress that we are hosting as part of this year's scientific program of the PCR Virtual Convention. I am Floribel Ravis, NPK's Corporate Events Consultant and your program facilitator for the next 3 days. To begin, I should say that this is one meaningful opportunity for us to continuously be part of the PCR's yearly conference. Needless to say, this year is a totally different setup and so much adjustments took place as we are holding this virtually, an approach to the new normal while the pandemic is still putting us apart physically. But still, we are grateful and excited as our resource speakers will be facilitating new learning methods, analysis, and insightful facts relative to imaging and therapy. We hope that the topics we prepared for you today, tomorrow, and on the 25th will be well attended and that it will deliver new concepts, knowledge, and personal progress. With this in mind, allow me once again to welcome and greet you all a pleasant day as we officially commence the learning program. To start, I am pleased to introduce our very first speaker for this learning session. Our resource speaker is a graduate of BS Biology Accelerated and finished Doctor of Medicine at the University of Santo Tomas, Manila. She held her residency training in radiology and fellowship training in breast imaging at St. Luke's Medical Center, Quezon City. She also served as associate consultant for women's imaging and breast imaging here and abroad for several years. Her primary role is to train and supervise radiology residents and fellows in training with subspecialty in breast imaging. To date, our first speaker is affiliated with HealthCube Advanced Medical Imaging Unit and at Centuria Medical Makati as radiologist and lead radiologist. She is active in research and publication related to breast cancer imaging. Atop her medical expertise and demanding field, she still allowed time to extend help by serving the Filipino, our kababayans, through Tulay Lingap de Padre Pio Clinic and Gift to Life Foundation, where she is serving as volunteer radiologist. Today, she will be sharing her expertise and facilitate her topic on the role of functional breast imaging in the diagnosis, preoperative planning, and surveillance of breast cancer. Let us all welcome Dr. Maria Theresa Buenaflor.
Good morning, everyone, and welcome to the session of Functional Imaging in the Diagnosis, Preoperative Planning, and Surveillance of Breast Cancer. We will be discussing two evolving technologies in breast cancer imaging, namely contrast-enhanced mammography and molecular breast imaging, as well as discuss what their similarities and what their differences are. More importantly, we will also discuss how they figure into the current diagnostic workflow in breast cancer management and focus on their specific roles as will be detailed in the cases that will be shown later. Functional imaging is based on the principle of neoangiogenesis, wherein tumors enhance because of the abnormal blood vessels. Now, when the tumor cells are rapidly increasing in number, they tend to outgrow their blood supply, thus go into a relative state of hypoxia and secrete vascular endothelial growth factor, or VEGF. VEGF is a potent angiogenesis activator or a pro-angiogenic factor that stimulates the formation and proliferation of endothelial cells. The resultant abnormal vessels are tortuous and irregular with poorly efficient perfusion and are leaky, especially to macromolecules. And in contrast imaging, this is the particular vulnerability that is taken advantage of. In this particular slide, it shows you the comparison of the current modalities that are being used to screen and diagnose women for breast cancer. And on the on the other side, we likewise find the additional number of cancers that are seen corresponding to the particular modality. If you look at the combination of DBT plus ultrasound, it actually shows or picks up more breast cancer. But in contradistinction to a functional based imaging such as the gold standard, which is magnetic resonance imaging, MRI is able to illustrate or demonstrate more cancers. Now, two new emerging technologies, contrast mammography and molecular breast imaging, more or less have similar performance to MRI. That is why they are now poised to be become part of the diagnostic armamentarium in the diagnosis of breast cancer. Moreover, there is a shift now into what we call value based imaging. So, what is value based imaging and what does it add to the current diagnostic protocols? It is basically physiologic in approach in the diagnosis of breast cancer. These are for women that cannot undergo MRI or do not have access to MRI. The It is not hampered by the breast density, unlike in mammography. And it also leads to improved earlier detection and diagnosis of breast cancer, and likewise contribute to the improved survival of women. Now, what are the differences between contrast enhanced mammography and molecular breast imaging? Contrast enhanced mammography is basically an upgraded mammography machine which uses a dual energy X-ray source. So the same contraindications for using iodine-based contrast is the same for those who are allergic to iodine, pregnant or lactating women, those who have hyperthyroidism and elevated creatinine are some of the contraindications to getting this examination done. For the adverse reactions, it's very, very minimal. And what is required is the creatinine and a fasting at least 4 to 5 hours, similar to that of the protocol used in CT scan. Now, molecular breast imaging is a nuclear medicine imaging modality, which is a newer iteration of the earlier version, which was CT mammography, and and is interpreted alongside with a nuclear medicine physician. Now, the radiation source for molecular breast imaging is the radiopharmaceutical dye called technetium sestamibi. The contraindications are if patients are allergic to the dye and pregnant patients. And the adverse reactions are likewise very, very minimal. And what is required is just fasting of at least 3 hours. Now, the current machines in the market actually have the same configuration as that of your standard mammogram or DBT. So these are the examples of the machines that are currently being used. And to discuss conscious mammography first, it basically has the low energy beam, which is equivalent to the energy used for the standard mammogram, and the high energy beam, which is half of the dose of the low energy beam. But the image that is being used is actually not diagnostic. So we are just using two images in the conscious enhanced mammography, which is your low energy image and the recombined or subtracted image, from which the algorithm of the machine already shows you the areas which will just have an affinity for iodine. The additional radiation dose of contrast enhanced mammography is basically 20% of the routine standard full field digital mammogram, or the equivalent of an additional view. Next slide. This shows you an example of what the molecular breast image looks like. And this has the same, basically has the same mammographic projections. However, its limitation is that of the details in the of the margin of the findings. Therefore, the challenge with molecular breast imaging is a very good correlation between the mammogram and the molecular breast image, because there is some discrepancy in the size. They are not similar in in what you are used to seeing, but more or less you have an idea in terms of the location and laterality. Now, in terms of the radiation, this particular slide shows to you that the limit set by the Mammography Quality Standards Act, which was enacted as a law in the US, is at 3 milligray. Now, to compare, the 2D 2D plus 3D mammogram is somewhere about 1.2 millisieverts, which is still less than that of the standard or the limit set by the MQSA. So a contrast enhanced mammography image would be slightly higher than the 1.2 millisieverts, but still relatively less than the 3 milligray set by the MQSA. Now, molecular breast imaging also is within 2.4 millisieverts, but this is the whole body radiation. And as you can see, the annual background radiation that we are exposed to is at 10 millisieverts. So they have shown in studies that no carcinogenic effects have been shown if you are exposed to 2 to 10 millisieverts. Now, the annual radiation limit for a radiation worker in the US is actually 50 millisieverts in a year. Okay, now looking at the what are the indications for either of the exam. So for the first one, for contrast enhanced mammography, according to the white paper as seen on the Society of Breast Imaging online, they do put extent of disease to reduce unnecessary biopsies for treatment monitoring, high risk screening, and in addition to as an alternative to MRI as endorsed in the European Society of Breast Imaging. Commensurate with that, we look at now what are the indications for molecular breast imaging. And in the practice parameter in the American College of Radiology, we have the following: to detect for primary cancer, disease extent and staging as an adjunct for problem solving, neoadjuvant chemotherapy response, to detect recurrence, and likewise high risk screening. So if we look at the indications for both modalities, they pretty much have an overlap, and we will focus on the specific ones that are as we've itemized in the specific roles that we are looking into, is really for the is part of the treatment and how these modalities figure into the treatment planning of the patients. Now, most actually would have some reservations with newer technologies, particularly the clinicians, because they don't understand these emerging technologies. So, for me, what I basically start with is to have an open discussion with the clinicians and tell them and show them actually how this can work for them, what added value it does to their for their patients. And so we have come up with a sort of a simplified workflow in our setting, well, particularly for the conscious mammography, that the clinician starts with a clinical breast exam, the risk assessment for his or her patient. Now, which patients get these special exams? We look at we advise them to stratify which patients actually would benefit from it. Okay, for screening patients, these are basically the ones that have no subjective breast symptoms. They are low risk women. They also have no history of a prior biopsy with high risk lesions. And these are the ones that you can pretty much follow up with annual mammogram, ultrasound, depending on their findings. Now, for those women that are symptomatic, or if they present with clinically suspicious findings for malignancy without any initial or preliminary imaging done, those that have inconclusive imaging findings, for example, the finding in the mammogram is different from the ultrasound finding, or if there are multiple findings, or there are bilateral lesions to be resolved, and which ones to biopsy if there are more than two or three suspicious lesions. This is where these functional breast imaging modalities can actually help us and help the clinicians. So for as diagnostic workup, they can they may need creatinine if you are going for conscious mammography, or none if it's going to be molecular breast imaging. Now for breast functional breast imaging, what I have experienced is that it tends to shorten the diagnostic interval time to the definitive management, because more or less the outcome will be the same, whether it's going to be an oncologic surgical management or an oncologic medical management. Now, in treatment planning, which is where I think these two modalities actually have a lot to offer, is in terms of determining precisely tumor location and disease extent, which are important because in previously, most women would not need to have any of these newer modalities or extra exam done because of the cost, but but also because in terms of the management, there was only one type of treatment. They all just went for a mastectomy. But nowadays, with the improved medical uh, radiation therapy and surgical techniques, we also would need to keep abreast of the 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 changes in the management. For example, in surgery, if mastectomy is going to be offered, is it going to be a total mastectomy versus a subcutaneous or skin or nipple sparing mastectomy? Or is there going to be immediate or delayed reconstruction? Now, for breast conserving surgery, which we term as partial mastectomy, there is the integration now of plastic surgery techniques, and this is another sub specialization called oncoplastic breast surgery. So with these types of surgical techniques that are now being done, we also need to adjust to what the surgeons actually need from us in terms of information. Now, if it is on the medical end, it will determine whether if we are dealing with metastatic breast cancer or locally advanced breast cancer, because now it's easier, or it's actually beneficial for the patient to be started on neoadjuvant chemotherapy rather than surgery and then doing chemotherapy after. Patients will still need to have surgery at some point, but because of the current situation, particularly with the pandemic, we need to find ways in which we have to make it safe for those involved in the care of the patient to have as to maximize the time and the treatment that will be done to the patient. Now, in radiation therapy, we I'm sure all of you are familiar with whole breast irradiation. However, there is now a another subset of breast radiotherapy, which is called partial breast irradiation, which now includes intraoperative radiotherapy. And this is another add-on to what will be, in what will be asked of us in terms of giving the best information available. Now, what do we look for? We look for our disease extension, and we look at either whether are we dealing with a unifocal tumor, multifocal tumors, or multicentric. So what is the difference? So for unifocal tumor, there's only one in one breast. You can have you can have unifocal tumors per breast, but in for multifocal tumors, these are cancers that are located within the same area or within the same quadrant of the breast. And if these are small enough, this patient, or if the patient has rather large breasts, then she can opt to get a breast conserving surgery rather than a total mastectomy. Now, for multicentric um, cancers, these are cancers that are located in different areas or different quadrants of the breast. And if we find cancers like these are the patients that are not going to be good candidates for breast conserving therapy. Now, we will be focusing now on the breast conserving surgery and a little bit of what intraoperative radiotherapy is. So the principles of breast conserving surgery is based on doing ideal oncologic surgery with free margins and adequate local control of the disease. What it means with free margins is that there are no tumor cells seen at the periphery or the edge of what was taken. There is likewise immediate reconstruction and symmetrization of the breasts, and also the transposition of plastic surgery techniques into breast cancer surgery. When we look at the location of the tumor and what is being obtained, it is actually seen as a three-dimensional object with six sides. So you do have your anterior, posterior margin, your lateral or medial margins, depending on where your sample is taken, as well as your superficial and deep margins. So the superficial margins actually corresponds to the skin area. The deep margin is in the overlying the pectoralis margin, pectoralis muscle already. So even the orientation of the sample that will be taken out, and if you are going to check for it either as a specimen mammogram or under ultrasound guidance, the orientation would have to be the same so that the pathologist also understands how how this specimen was taken. Because, for example, if there is in a margin that has tumor at the edge or at the border, that is the area that the surgeon needs to go back for to get extra samples. They call it a cavity shave. So to illustrate further, this is an ideal way of obtaining a negative margin. So the periphery surrounding the tumor is has it only contains normal tissue, Now, if you have tumors at the edge, that means that patient has positive margins. Correlating that with how we look at and mark this for oncoplastic breast surgery. Oncoplastic breast surgery involves, so the difference between oncoplastic breast surgery and just plain lumpectomy is just taking out the lump or the tumor. That is not the definitive cancer surgery. But in oncoplastic breast surgery, you do take the tumor and the margin surrounding it. So from the medial and lateral margins of the tumor, we ideally there is about a 1 centimeter and 1 centimeter margin circumferentially, so that to be able to obtain a total um, excision of the tumor with negative margins. And the correlate images that I am showing to you is that of a very small tumor and the corresponding specimen mammogram of that particular case. Now, to touch on briefly on the intraoperative radiation therapy, in the same cavity that the tumor was taken out, if you already have the clear margins, the the intra the radiation oncologist will position the applicator and will be flushed against the cavity where the tumor was taken, and it will radiate an additional 1 centimeter peripherally. So on top of the margins that was taken, you do have an extra 1 centimeter of breast tissues that is being irradiated, because as we know, the tendency for recurrence usually occurs within 1 centimeter from your um, primary tumor. Okay, now we will go now into the exciting part, which is basically the discussion and how to go about in managing difficult cases and challenging ones. So to begin with, we have a 49-year-old female. She came in for just routine mammogram. She has no subjective breast symptoms and no family history of breast cancer. If you look at her standard MLO and CC, you and in the cropped area, in the highlighted area on the CC view, I inverted the image to be able to appreciate these groups of calcifications. If initially you will just look at the calcifications, you will think, am I going to be sending both areas for biopsy? And that would be typical. Now, since this patient was actually a physician, so I gave her the option of undergoing a conscious mammogram for us to be able to determine if we really are just dealing with one or are we dealing with two, because that would change the outcome of her management. Now, if you look at the subtracted image of the right and of the right MLO and CC, you see these sort of linear non-mass enhancement corresponding to the area of the microcalcifications in the immediate retroareolar area. And in the other area, which was in the posterior medial uh, of the right breast, it showed no corresponding enhancement. So she was sent for tomosynthesis guided biopsy, and true enough, that area which had the uptake with the abnormal, with the group microcalcifications, turned out to be ductal carcinoma in situ with suspicious focus of microinvasion. Since the other group microcalcifications did not have any uptake, that did not have that was not recommended for the um, biopsy. However, this patient opted for a subcutaneous mastectomy with a tram flap. Now, the next case is a 40-year-old female. She is post lumpectomy for invasive breast cancer, had whole breast radiation and chemotherapy, and this was when she was 31 years of age. Now, in a routine mammogram, there was note of interval screen detected group of microcalcifications, again in the left breast at the mid to inner um, aspect, approximately in the 11 to 12 o'clock position. So we look at her bilateral mammogram, which shows heterogeneously dense breasts, and in the area outlined by the square box, which I also inverted, we see this group of coarse heterogeneous microcalcifications and the corresponding area on the left MLO. So I suggested to her to also undergo a conscious mammogram, and on the subtracted images, we are able to appreciate again corresponding enhancement of the suspicious group microcalcifications in the upper mid to inner quadrant. And likewise, we take note that this area is about 1 centimeter medial from the area of her previous lumpectomy. And more importantly, we see no suspicious or abnormal enhancement in the right breast. Therefore, we are confident that we are dealing with a unifocal area, and the outcome, eventually she went for a mastectomy because this is considered a recurrence. And what was seen was a 9 millimeter area of DCIS with foci of invasions, the largest of which is at 2 millimeters. Okay, our next case is a 47-year-old female with a family history of breast cancer, her maternal grandmother. So she presented with a palpable mass in the right breast. However, this is where it gets interesting. Initially, she had a breast ultrasound which noted a Byard's 5 lesion at the upper outer quadrant of the right breast. The measurement then was around 2.4 by 2 by 2.4 centimeters. And she underwent a core biopsy. However, the result just said atypical cells. Now, when it says atypical cells suspicious for malignancy, the sample obtained is not adequate, especially when you would like to determine the specific tumor biology, and if you are going to and if it is adequate enough to be sent for a breast panel. So and a follow up with her medical oncologist revealed that on clinical palpation it actually was around 6 centimeters. Now, if you look at barely 2 weeks, comparing the size on the ultrasound study and on the clinical breast exam, there is some discrepancy. So, are you dealing with a very rapidly enlarging mass? But I really don't think in a very short time it's going to, you know, to to grow that fast in 2 weeks. So, likewise, there was also the the result of the core biopsy, which was not very helpful. So she was actually a good candidate to have contrast mammogram done and a repeat core biopsy. So if you look at her breasts, she also has very dense, she has dense breasts And you can see some area of um, increased density in the right in the right breast, particularly in the retroareolar, where you see some distortion, and you can also see some nipple retraction. And comparing the symmetry of the breast, the right breast actually is slightly smaller compared to the one on the left. On the left side, you can see some partly circumscribed equal density masses also. Now, on the subtracted images, what we see here is basically a very avidly enhancing non-mass area in the right breast, and the measurement was actually up to about 12 centimeter, and that's extensive compared the to the initial measurement seen on ultrasound, likewise on the clinical breast exam. Also, you see similarly enhancing masses in both breasts, but there is one on the left breast in the lower inner quadrant that is enhancing more than the rest of them. So, since we are dealing with a more or less locally advanced cancer on the right, the decision to biopsy the one in the left breast was also taken into consideration. So, in the same day, the left breast mass that was enhancing more compared to the rest of the other smaller circumscribed masses was done, and it turned out to be a fibroadenoma. But even if it was benign, at least we made sure that you will not be dealing with another cancer on the contralateral breast, knowing that a local you have a more extensive involvement of the right breast. Now, actually, in the right breast, you can also make out some fairly circumscribed smaller masses, and because of this, we use this as a guide to be able to biopsy and have a better yield. And true enough, turned out to be invasive ductal carcinoma with apocrine and lobular features. So this patient eventually went on to have neoadjuvant chemotherapy first and finished her chemotherapy before she proceeded with her mastectomy. Okay. Our next case is a 41-year-old female with no known family history of breast cancer. She has a HER2 positive malignancy on the left breast and is on the mid-cycle of her neoadjuvant chemotherapy. So looking at the imaging studies that she has had done, her initial test was a breast MRI, which showed a fairly large area in the outer left breast. And on her PET CT scan, you're also able to see the area that is hypermetabolic. And on her, on the mid cycle, roughly on her mid cycle of her neoadjuvant chemotherapy, she underwent digital mammogram and was referred for contrast mammography prior to her surgery. And we are looking at now her standard digital mammogram, which also shows you dense breasts. And on the subtracted images on the right, we have no abnormal enhancement in the right breast. In the left breast, however, we do take note of this large area with microcalcifications in the outlined um, box and showing some mild enhancement on the subtracted image as likewise outlined and magnified. We also take note that there is a round mildly enhancing axillary lymph node. So here we are able to appreciate much better the extent of these microcalcifications on the outer breast. And on the 2 minutes of the acquisition, we are able to see that this area corresponds to some degree of enhancement, while on the delayed view in 5 to 6 minutes after, we see that it almost actually does not show any more enhancement. So for this particular patient, she still underwent a mastectomy. Now for our last uh, case, we also have a 41-year-old female with a family history of breast cancer, a paternal aunt in her 50s, and a maternal cousin who had breast cancer at the age of 39. She had a right breast non-palpable mass, which was seen on ultrasound and recommended for biopsy last year in 2019. And on her follow-up ultrasound was still noted with no increase in size. So instead of recommending her for a baseline diagnostic mammogram, um, she was she agreed to have a conscious mammogram done instead. And as we see here in the standard and subtracted MLO images of both breasts, we see dense breasts. And then in the subtracted images, we're actually picking out unifocal masses in both breasts. Likewise, her corresponding CC views in the standard and subtracted views likewise shows one lesion per breast. And both of these were biopsied and turned out to be invasive carcinoma. She eventually had breast conserving surgery for both breasts, and fortunately, she had negative lymph nodes. Now, this is a process flow that we did uh, with some clinicians, and we this is how we were able to integrate the use of conscious mammography among Filipino patients. And so far, we have had no adverse contrast reaction. And for those that had enhancement, these patients, those that had enhancement proceeded to image guided biopsy and had their pathology correlated with their imaging findings. And for those which did not have any enhancement, they just had close follow up with their clinicians in 6 months and the appropriate imaging as necessary. And what we were able to determine was that when we used or integrated conscious mammography to the diagnostic workflow, we were able to actually see a 44% conversion of our imaging to procedure as biopsy. And from those that had the abnormal enhancement, 80% of them actually converted to surgical procedures, two of which were just surgical excisions because of high risk lesions, nine for mastectomy because of malignancy, and one who opted for prophylactic mastectomy because of a typical ductal hyperplasia. She has two sisters who had breast cancer. So this is how for this particular modality, we are able to see how it can actually help in improving our diagnostic pickup. Moving on to the latter part of our case-based approach, we now go through the molecular breast imaging cases. And just as a reminder, we do read molecular breast imaging in conjunction with a nuclear medicine physician. To start with, we have a 78-year-old female with no family history of breast cancer. She presented with interval screen detected microcalcifications with an associated density at the upper outer left breast. If we look at her MLO for clarity, we outlined that area and you can see the microcalcifications. And she proceeded with a molecular breast imaging, which showed that area to actually have an uptake. And more importantly, the right breast shows none. So she proceeded with a stereotactic guided core biopsy, which showed lobular carcinoma in situ. And she eventually was noted, in addition to the LCIS, actually had a focus of DCIS. So she was a good candidate for a partial mastectomy with sentinel lymph node biopsy and intraoperative radiotherapy. So the planning that went into the the patient actually was based on the findings in the mammogram as guided by under mammogram guidance and correlating it with the particular area of uptake. And the final histopathology did show ductal carcinoma in situ with cribriform, comedo, and solid types, and a negative um, sentinel node. And her 6 months follow up mammogram shows to you the area with very minimal post surgical or radiation changes. Next patient is a 47-year-old female with a family history of breast cancer. Her mother actually had stage 4 breast cancer. She is likewise asymptomatic but had a suspicious mass seen on ultrasound in the left breast. Review of her outside mammogram showed that she had heterogeneously dense breasts, and her risk assessment showed that her lifetime risk of getting breast cancer with positive family history, likewise with dense breasts, was very high, which was about 21%, as compared to that of an average woman with a lifetime risk of about 8%. So her molecular breast image showed a unifocal area in the upper outer quadrant of the left breast, which had an uptake and was found on ultrasound and eventually biopsied. And it did turn out to be invasive mammary carcinoma. So she opted to undergo breast conservation therapy, and using the same um, findings on the ultrasound, had wire localization under ultrasound guidance, and we were able to get exactly the tumor with clear margins as shown on the specimen mammogram in the middle image. And she likewise had negative sentinel lymph nodes, underwent intraoperative radiotherapy, and on the far right images, you can see her follow up mammograms in 6 months, likewise with minimal post surgical changes. Our next patient is a 59-year-old female. It had a palpable mass in the left lower outer breast. She was post excisional biopsy for ductal carcinoma in situ. However, initial scanning by ultrasound showed that there was actually another irregular hypoechoic lesion medial to the previously biopsied, incompletely biopsied lesion, and was referred for molecular breast imaging. And true enough, molecular breast imaging showed the uptake of these two lesions. Now, this patient also opted for breast conservation. The question was, could she safely, or is a good candidate to undergo such procedure? And taking into account breast size if and size of the tumors, and knowing that these tumors are multifocal, yes, she was a good candidate and underwent wire localization with complete with complete excision of the two tumors, the two adjacent tumors, the larger tumor being DCIS, while the smaller tumor at the 6 o'clock position was actually invasive carcinoma. Now, our next case is a 61-year-old female presenting with a palpable mass in the upper outer quadrant of the right breast. She was already diagnosed to be invasive ductal carcinoma, hormone positive. However, family history likewise showed that her sister had breast cancer. Now, her molecular breast imaging showed a, an multiple hypermetabolic masses in the upper outer quadrant of the right breast. And as you can see on the corresponding ultrasound, was also um, hypervascular. So for staging workup, she was sent for PET CT scan, and these showed that her in the area of the right breast, you still see those hypermetabolic masses, but more than that, you see um, multiple hypermetabolic foci in the spine, and which were which made her metastatic. Therefore, she eventually was initiated already on neoadjuvant chemotherapy. Now, another patient, 46-year-old patient, presented with pain and an area of thickening in the mid-outer breast on the right. So the mammogram shows you where an area of distortion is corresponding to the area with a focal skin retraction. So it was the corresponding finding was found on the breast ultrasound and biopsy, and turned out to be invasive ductal carcinoma with lobular features. Initially, the patient wanted to undergo breast conservation surgery, but before that can be safely done, we needed to find out whether she was actually a good candidate, and thus molecular breast imaging was performed, and it showed a fairly large area of enhancement, not with no not corresponding large area, a fairly large area of uptake, more than what was initially seen on the ultrasound. And since there is also some linear uptake extending up to the nipple, this patient was not actually a good candidate for breast conservation, and instead had mastectomy with sentinel lymph node biopsy. She is fortunate, however, that no abnormal uptake was seen in the left breast. Now, lastly, we have a 61-year-old female who also has a palpable mass in the right breast, which was already diagnosed as invasive carcinoma and scheduled for mastectomy. However, she sought second opinion and was referred for molecular breast imaging for disease extent evaluation. From her molecular breast images on the left, we're able to appreciate an area of uptake at the upper mid to inner quadrant, corresponding to an area of group calcifications, as you can see on the as encircled. Now, this was there was either a choice of you can either do send this one for stereotactic, or you can try to look for a corresponding lesion on the ultrasound, and that we opted for the latter. And there were two lesions in that corresponding area. The first one turned out to be a fibroadenoma, while the other area was a confirmed DCIS. So instead of an initial unilateral mastectomy, this patient ended up with a bilateral mastectomy, and fortunately for her, had negative sentinel lymph nodes. Now, this slide I would just like to share with you is really the integration of a functional imaging such as molecular breast imaging in the diagnostic workflow, and how it can lead to pickup of earlier cancers with no um, involvement of the axilla. So we were able to establish with this case series that you can determine unifocal or multifocal cancers. You can likewise determine the disease extent, and we have likewise proven that it is essential for preoperative planning. Therefore, in conclusion, we are able to establish that that functional breast imaging is here to augment anatomic based imaging and add value to the patient care. The following shows you that it is able to detect cancer. It can detect additional foci of cancer in newly diagnosed breast cancers. It, it is a good tool in the problem solving of complex clinical and imaging cases. It can be applied for those who are at increased risk of breast cancer, and importantly adds value to the decision making in the treatment. We also realize how it can impact the collaborative care and management of breast cancer as we transition into more personalized and value based imaging. Thank you so much for your attention, and I hope you enjoyed this session. Please do send us your questions, and we would be more than happy to answer them for you. Thank you and have a good day.
Once again, it has been Dr. Maria Theresa Buenaflor with her topic, the role of functional breast imaging in the diagnosis, preoperative planning, and surveillance of breast cancer. Thank you so much, Dr. Buenaflor, and of course to everyone who are still with us participating on our mini session. We are hoping that everyone here today will join us again tomorrow as another subject matter expert will speak and share facts and significant studies relevant on our scientific program objectives. I am Floribel Ravis, Corporate Events Consultant and Program Facilitator for NPK Medical Training Incorporated. Enjoy the rest of the day and see you all tomorrow. Thank you.